All right, everyone. Well, we wanted to give a big welcome from the Accommodations Committee. And today we're going to be talking to you a little bit with some of the most common and useful, hopefully useful tips for treating patients with disabilities in the emergency department. I'm Dr. Annika Baxter. I'm with Emory University.
I'm
Uh,
Jason Rizzoli. I'm from the University of Rochester.
And I'm Dr. Corey Poffenberger from the University of New Mexico. So I'm going to start us off. First of all, our objectives for this talk are first to discuss why health disparities exist for patients with disabilities and those who require accommodations but may not identify as having a disability. We're going to discuss the medical and social models of disability and the impact that these approaches can have on patient care. And finally, we're going to provide examples of strategies to deliver more equitable and culturally sensitive care for patients with physical disabilities, but we're going to talk about this for other types of disabilities as well. So I'll start us off by talking about the difference between disability and disease. So we spend a lot of time, obviously, in healthcare, taking care of people with diseases, diagnosing diseases, and the word disease refers to a biomedical condition, which is defined in terms of its underlying cause. And comparing that to illness, illness is more refers to the subjective feelings a person might have, maybe about their disease. It can refer to feelings of pain, compromised health, or well-being. And then finally, we have disability, which is not a disease nor an illness, and may not even be a distinctive biomedical condition. And obviously, different types of disabilities can be caused by a wide variety of conditions. So if disability is not a disease or illness, then what is it? If you look up disability in, online, search for the definition, you might see something like this, which says a physical or mental condition that limits a person's movements, senses, or activities. Synonyms are handicap and some of these other words that are very negative in nature. In contrast, the definition that I really like to use is this one by the WHO, which states that disability is an umbrella term covering impairments, activity limitations, and participation restrictions. Disability is thus not just a health problem, but a complex phenomenon reflecting the interaction between features of a person's body and features of the society in which he or she lives. And this definition is the basis for something called the International Classification of Functioning, which is kind of a biopsychosocial model of disability. We're going to talk more about disability models in just a minute. So disability is common. It affects more than 1 billion people worldwide. In the United States, it's 1 in 4 or 25% of the population meet the definition of disability. So as I mentioned, we were going to come back to the models of disability. And so the medical model of disability is probably the one that is most utilized and you may be most familiar with, even though you may not know it as that. And the medical model of disability states that people are disabled by their impairments or differences. It focuses on what is different about somebody and aims to fix those differences or impairments through medical solutions. So as you can see in this picture, the issue is the individual, and the individual needs to change to fit in with everyone else in the world. In contrast, the social model of disability says that disability is caused by the way society is organized rather than by a person's impairments or differences. It focuses on removing barriers that restrict choice for people with disabilities so they can be more free and independent in the world. So again, in this picture, the issue is the inaccessible world. It's the way that we have designed our society, our structures, and our policies to favor those who don't have disabilities and to exclude those who do have disabilities. We all know in reality there is some component of both of these models in the real world, but I think the social model is very helpful for us to think about the ways in which we, as a society, are excluding those with disabilities. An example of the social model of disability would be someone who is culturally deaf or deaf with a capital D. When in their own society, they don't have the experience of disability and don't identify as someone with a disability. Their experience of disability comes when they interact with the outside society, outside of their culture, those who are hearing, and then they have the experience of disability. So as I mentioned, there are many types of disabilities, and disability can cover everything from physical limitations, such as those who might have difficulty walking or climbing, or those who might use wheelchairs, vision difficulties, those who are blind or have serious difficulty seeing, hearing difficulties, those who are deaf or have other hearing challenges. And it covers all the way up to learning disabilities, which obviously are very common, things like ADHD or other specific learning disabilities, as well as intellectual disabilities, things like autism or Down syndrome, other developmental disabilities. So disability is obviously very heterogeneous. And so the experience of people with disabilities can vary in healthcare. But what we do know is that while the experience of the experience of people with disabilities can vary, we do know that the experience of people with disabilities is generally poor when it comes to their interactions with healthcare providers. In fact, they state that they are highly likely to find provider skills and facilities inadequate. They are 3 times more likely to be denied healthcare, and they're 4 times more likely to be treated badly in the healthcare system. This is data that comes from the WHO. And so why do healthcare disparities exist for people with disabilities? Well, the simple answer is ableism, which is discrimination in favor of able-bodied people. And again, ableism is a dominant mode of function in our society, and it is entrenched in healthcare. And so if you look at this graphic of barriers to healthcare for people with disabilities, the reason all of these barriers exist is because of ableism that is entrenched within our systems. So the health environment, there's an absence of disability standards and provider training. That's something that we as a group have been working on to try to educate healthcare providers on how to better care for and interact with people with disabilities. There's a lack of research and insufficient data on the health of people with disabilities. There's a lack of inclusive health promotion programs. Those are all pieces of the healthcare environment. In addition, if you think about our healthcare system, things like scheduling restraints, lack of appropriate services and supports for people with disabilities so that they can be more independent. If those supports are not put into place, then people their experience may be more restricted. In the office setting, inaccessible office and equipment, there was a study of primary care clinics in California that found that a large percentage of them were actually inaccessible to someone who used a wheelchair. And then again, lack of staff training as well as provider training. The people with disabilities interact with in the emergency department, from the registration clerks to the techs to the nurses. Everybody has a role in making that patient feel welcome and supported, and they also have a role in making that patient feel unwelcome. So, and then at the tip of this is the provider. So again, lack of disability training, poor attitudes or biases, thinking that patients with disabilities have a poor quality of life, and just an incomplete knowledge of what people with disabilities need in terms of language, in terms of etiquette, and in terms of care coordination. And so, we hope that this will be one way in which you guys can all learn how to better interact with people with disabilities on your emergency department shifts. So I'm going to go over a couple of pieces of general etiquette, but then later, Jason and Annika are going to talk more about specific types of disabilities and some more etiquette. So first of all, this may seem obvious, but introduce yourself and speak to the patient first. Even if you know that they might have an intellectual disability, even if you might have heard or through the chart that they don't speak, it's still very important to speak to the patient first, because we don't want to be making any assumptions about whether a patient with a disability can participate in their care, whether they can communicate. It's best to just really keep an open mind and to start with this piece of speaking to the patient. You definitely do not want to make any assumptions about any person who might be with the patient in terms of who they are. I've heard stories from patients with disabilities about providers talking to someone who was just the driver who brought them there. So it's really important that you don't make any assumptions about who this person might be just because they happen to be with a person who has a disability. When in doubt, ask the patient. And so I think sometimes we're really afraid to ask because we don't want to offend or we don't want to say the wrong thing. but patients with disabilities would really prefer to be asked these questions rather than to have you make assumptions. So ask how they prefer to be examined or how they prefer to communicate if it's not clear to you. Ask them if they need an accommodation for the visit, and then provide the accommodation if they ask for one. Some people may not understand those words, so you could also reframe it as, are there any supports you need for this visit? Or is there anything I can do to make this visit easier for you? And then ask how they refer to their disability. So people with disabilities sometimes prefer person first language, which again would make them a person with a disability. But some people with disabilities actually prefer what we call identity first language, which would you would refer to them as a disabled person. Or specifically, like if you were referring to someone with autism, it would be an autistic person versus a person with autism. So, you know, there are different reasons why different people prefer one or the other, but I think it can be helpful if it's relevant to your conversations to ask them. So I think next I'm gonna hand it over to Jason.
Wonderful. Thank you, Corey. So I'd like to take the opportunity to introduce the Deaf American Sign Language user. And while they technically do fall under the classification of having a disability under the ADA for protection, this is a group of people who don't identify as being disabled. So on the right-hand side of the table, this is a group of people who are born deaf or go deaf at an early age and use American Sign Language as their primary language. They view their deafness from a cultural perspective or through a cultural lens, and they identify with a group of people with a common history and life experience and language. And this is in stark contrast to people who have deafness in their old age. And so you can think about our parents or grandparents who may have presbycusis, and they feel hearing impaired or a loss by the difficulty hearing that they have acquired. And that's because they belong to a hearing world and they identify with a spoken language. They view their deafness medically, and that is to say as a problem that needs to be fixed. And this is very different from how the deaf ASL user views their deafness. I want you all to think about the Deaf American Sign Language user as a marginalized group of people because they are in a marginalized community and they, as such, have limited access to information and education since American Sign Language is their first language. This results often in lower English literacy skills and health literacy, which leads to a lot of different comorbidities, and also results in higher percentage of vocational jobs and lower percentages of advanced degrees. And all of this collectively results in lower socioeconomic advancement and achievement. So there are some things that providers do that create barriers to care for the deaf ASL user. One of the most common things that we do is we rely too much on lip reading. And lip reading the English language is incredibly difficult. And if you think about it, the words that happen inside the mouth, or the parts of the words that happen inside of the mouth, like M's and N's and D's and T's, they're nearly impossible to lip read. You also have to put this in the context that this is a second language for the deaf ASL user. So they're trying to lip read now a second language. And then when you add in medical terminology that the person may have never heard of before, it makes it nearly impossible and quite dangerous. There is also a provider tendency to focus on the person's deafness when they come in for a visit, even when it's completely unrelated. And this is a really great way to put up a roadblock in trying to establish a rapport with your patient. Something else that Corey mentioned about communication preferences that we don't do well is either not provide an American Sign Language interpreter or ignore the communication preference that the patient has requested because it's not something that we are comfortable with. And again, this is another way to really put up a roadblock in terms of patient-provider rapport, but also in terms of adequate communication during the encounter. Speaking of interpreters, when we do have an interpreter present, there's often inappropriate habits while working with the interpreter. And these are things like positioning the interpreter where the patient can't see the interpreter, or directing your language or your attention only at the interpreter and essentially excluding the patient from their own health visit. And one of the final things that we do with many patients is the use of really complex written or medical terminology, which has its challenges in conveying information adequately to the patient. So I just want to emphasize a point again about lip reading. In the picture of the gentleman on top who has a beard, almost his entire face is covered. Certainly his mouth is covered, making it nearly impossible to lip read what he's saying. Then you have the person wearing the mask either during a procedure or during times of COVID. Again, the whole mouth and the entire face is covered, which would make lip reading impossible. And then the last picture is of this woman who is from England. So she speaks English, but she has an accent and she uses different words than someone from the US might use, again, creating just an additional barrier for lip reading. So I want to emphasize, please do not rely on lip reading. The deaf community finds it often offensive when they're asked to lip read, and really try to establish communication preferences. So there are some barriers to care on the patient side as well. Being part of a marginalized group, the patient does have an innate sense of mistrust of the provider. There's a fear of language and cultural discordance and a fear of inaccurate information exchange between the patient and the provider. There's also the fear of appearing uneducated within the community, not knowing what questions to ask or what even an important question would be to ask. And all of these patient and provider barriers culminate in increased comorbidities within the community. And that is risk of increased obesity, intimate partner violence, suicide, and also lack of awareness of stroke and cardiovascular system symptoms. So some tips to providing accommodations for your ASL user is to first recognize that this person belongs to a marginalized group. They are capital D deaf and use American Sign Language, and they are not the group of people who are hearing impaired or have presbycusis. Again, like Corey mentioned, ask about communication preferences and then do your best to follow them and provide those accommodations. And by all means, please try to avoid lip reading. Lastly, don't make assumptions. It is our job to describe and explain diseases and procedures and any medications that we may be providing, but it needs to be done in plain language so that there's adequate comprehension for the patient, so they understand what we're talking about. And now I'm going to turn it over to Annika.
Alrighty. So as you can see, a good amount of people in the US deal with visual impairments. And of these, it's just good to remember that a good number of those are over age 55. Some tips for dealing with people who are blind or visually impaired. Make sure you're identifying yourself when you enter a room. For example, hi, I'm Dr. So-and-so. The nurse is here with me, etc. And be sure you do this every time you enter the room, because obviously they're not going to see you enter the room. And also, it's just very hard to identify someone immediately just off of the sound of their voice. You can also use a little bit of light touch to make sure the person's aware you're talking to them, especially if there are other people also in the room. And then be sure to give specific directions. So for example, the call box is next to your left hand, as opposed to just it's over there. Don't worry too much about what choice of words you're using. People generally don't find it offensive, so don't worry about using general colloquialisms, etc. Remember, or perhaps you're not aware, but when you want to try and guide someone who's visually impaired or blind, the best way to guide them is to have them hold onto your upper arm. It's also probably the safest because it gives you the most stability, and them as well the most stability. Uh, Again, most importantly, ask them what they would like, how they would like to, be helped, or how they would like to be shown to, whatever area, and then offer, your upper arm to use. Never grab the person, never force steer them or anything like that. Those are very important things to know. Some tips on interacting with people who are using a wheelchair. Again, ask people what they need. That's probably the most important thing. Also make sure that anything they may need when you leave them alone in the room, that it's all within like arm's reach, or they have a way to ask for help if they need something. That's very important. A lot of times you'll, take for granted that someone can just reach the call box and or whatever little call thing. And, for someone, if you've move them from their wheelchair, especially into the bed to examine them, now they no longer have that accessibility. So make sure to ask them what they need before you leave the room, um, and make sure that it's provided and close enough for them to get a hold of on their own. Remember in interacting with service dogs that there are, as Corey mentioned earlier, many types of disabilities, and likewise, there are many types of disabilities that may use service animals. Seeing impaired is probably what we usually think of, but there are other physical impairments that dogs are trained, or other animals even are trained now for, psychiatric um, disorders and other types of medical alerts that you may not be aware of. So remember that the animal, when it's with the person, is a working animal. It's not a pet at this time, no matter how cute they may be, and you know that they're doing a good job. Don't treat them like a pet. Always ask. If you really feel the need to pet the animal, then make sure you're asking the person if you may pet the animal. Likewise, it's a good idea to ask the patient or person how you might help them with the animal. If the person is anticipated to, say, need a CAT scan and it's going to take hours, you might ask them about like animal relief and if you can help them with that, and just kind of check in on that. So this is a little tricky. I feel like it's what everyone wants to know. Is the animal actually a service animal? Um, And you want to be polite just because you respect the person, but also there's legal ramifications. So really there are two questions that you can ask. The first is that just simply, is this an animal that's required because of a disability? The other question is what work or task the animal has been trained to perform. And that's really the only two questions you can ask. And if you feel like you need to ask it because it's not obvious, then I also like to follow up um, with a bit of sensitivity as to why you're asking it. So, for example, if the animal is trained to perform a task, it's very helpful to us to know because, for example, if it's an alert dog and they start acting bizarre, is it because this person is about to have whatever they're trying to alert you for? So it helps you on both sides. Or, just what is the alert they're trained to do. And then just again to kind of summarize everything, some general tips. Again, ask, ask, ask. You can't ask too much. Be sensitive in your asking. This is you're being patient centered, so asking is really helpful. Um, Remember to tell your patient what it is you're about to do before you do it, or communicate with them however best they've already, delineated. And then try and practice using the patient-centered language. For example, like someone who uses a wheelchair, or someone who's visually impaired, or someone who is blind, as opposed to it's just a blind person. Um, we mentioned that certain people have their own preferences as to how they want to be referred, but I think we really don't have much of a good practice using patient-centered language. So it's a good idea to start at least practicing it when you're around your colleagues. If there are any questions, I think you see our emails. Please feel free to reach out to any of us. We'd love to answer questions.